We will wait one more minute and then we'll get started. It looks like we have almost every facility on. If you go to the 3 dots next to your name, you can put like comma your facility. That's always helpful for everyone so we can remember where everyone's from. Okay, it looks like we're at 2:02, so I think we can get started. I'm going to take us out of share for a moment so we can see everyone. So at least, or I can see everyone instead of just a couple little tiny boxes. If you have video and you want to come on video, I was going to join. Well, first I'll introduce the Flex team. We'll introduce ourselves and then we'll just go through each hospital team. So I think you all know me, but I'm Debbie Lowenthal here at the Alaska Hospital and Healthcare Association and part of the Flex team. I'm the manager of programs and services here. And do you, Lynn, why don't you go next and then the rest of the Flex team?
Hi, everybody. Lynn Van Vector, Director of Quality and Performance Improvement with AHA. Nice to see you guys.
Great. And Kate?
Hi, Kate Harmon with the Department of Health. I'm the Small Rural Hospital Program Manager there.
And I'm Erin Ackelstead with Mountain Pacific Quality Health. I'm a quality consultant.
Great, great. So why don't we move on to our hospital teams? And I have Bartlett, and I don't know, Jeanette, are you the only one on from Bartlett right now?
Yeah, I am. I just,
Okay.
I'm not sure if Deb Kelch was going to be able to join, but she's my partner in quality. But I'm Jeanette Lacey. I'm the Director of Case Management.
Great, thanks, Jeanette. And Mike with South Penn. Mike, I can't hear you. I'm not sure. We could come back to you. And Kodiak, do you want to introduce? There's more than, let's see, is it just you, Jen?
Nope, me and Tammy.
Oh, Tammy. Oh, and Tammy, of course. Yeah. So you guys can, sorry, Tammy. Yeah. I was talking to you earlier, so go ahead if you guys want to introduce yourself. And if there's anyone else on your team that's going to be part of it that you want to introduce that are not here, that would be great too.
Okay, well, I'll go. Hey, I'm Jen Mooney. I'm the Executive Director of Operations in Kodiak, and I get to work with quality and both at the hospital and at our long-term care.
Great.
Hi, and I'm Tammy. I'm here in Kodiak as part of the quality team.
Hello.
Wonderful. Mike, did you have sound now? Do you want to try?
Maybe. Can you hear me now?
Yeah, we can hear you.
Mike Tupper, Quality Support Specialist at South Peninsula Hospital. And then I think I saw Amy was on as well. And she is going to be part of this project. Are you there, Amy?
I am, but I'm multitasking today. So
No worries.
I don't want to be rude, but I have some stuff that I have to take care of. So I was just going to try to listen in.
Oh, wonderful. We're just glad you can be here and we have the recording. And if you need to pop out, no worries at all.
Great. Thank you.
And Mike, do you want to mention, so Jane, do you want to mention that Jane will be kind of working on this project and you're kind of assisting as you transition?
Yeah, sure. So I took a different role in our organization. And so I'm handing this kind of project over to Jane Noller, is our acute care director. And she just happens to be out right now. And so I figured I would be here for our team for the moment. And then I'll be moving out of this role by, a couple weeks from now. And then Jane will kind of be taken over as the project lead.
Great. Thanks so much for being here, Mike. And then Kristen? Where'd she go?
Hi, I'm Kristen in Seward. I'm the Quality Regulatory Services Manager, and I have Trish with me. She's our case manager. And Andrew had the invite. He's our director of nursing. He may join or not today.
Great. Wonderful. Thanks for being here. Welcome, Trish. And looks like Valdez isn't on. I don't see. And we have Helen is actually taking the CPHQ test, I think. I don't know if I'm allowed to say that. I just did though. But so Monica, you're on, so welcome.
Hi, good afternoon. I'm Monica. I work with quality at Manilic, and I will be working with Helen on this project.
Great, we're so excited you guys are continuing. And now we have Eric from Search, and I know they're still considering being part of this collaborative, and I asked him to just join and listen in to see what he thought. And I'm going to also kind of celebrate him because last week he passed the CPHQ exam. Yay! And you've just been in your role a few months, so that's amazing. So glad you can join. Is there anything else you want to just say hi real quick?
No, I think that about sums it up. Yep, just here to gain some information, and been in this role for about 3 months, but with Search coming on to 5 years or so.
Great. Okay, I'm going to go back to sharing this. We're really excited. You all can be on and want to participate in the collaborative. And let's see, let me get to this. Okay, I know all of the hospitals actually were part of the collaborative that are on, but I just wanted to there's a few new team members. So I just wanted to give a really brief summary of last year in the collaborative. And one of the things, the reason we launched this project in the first place was we are part of our state, and most of the other states in the US get funds through HRSA on the FLEX program, which is the Medicare Rural Hospital Flexibility Program. And that's one of our programs we work with on quality. The other one is the HQIC, the Hospital Quality Improvement Contractor with Telligent. So we have kind of two quality programs we work on. And with Flex last year, for the first time ever, they asked every state to do a QI project. And so when we initiated that, we're like, well, what topic should we pick? And we decided to look at readmissions. We knew that we had kind of a higher rate than the Telligent network rate of 12.8 per 1,000 discharged for 2021. And so with readmissions being so costly and disruptive, as we all know, for patients and families, and very often very preventable, we thought this is what we want to really work on with the hospitals. And we were so excited to get 10 hospitals that participated last year, and you are all one of those. So thank you for continuing on with us. And when we launched the project, we're like, well, what are we going to do? And Lynn had seen Dr. Amy Boutwell and her work with the Aspire model and readmissions and the whole patient and care transitions. And she's going to talk a little bit more about that later, because we're going to continue with that Aspire, and that's how we're going to look at the data again. But we're going to be really focusing on health equity and social drivers of health along with that this year. And our goal was a 3% reduction in Medicare readmissions, and that was last year's goal. And as most of you know, because you all participated, a lot of you did with our learning sessions and coaching calls. There was in-person training on health literacy. We had posters I'm going to show you a couple pictures of shortly. And with the health literacy, we worked on completing culturally competent discharge instructions. And this is just kind of an overview. I think you've seen this. It was in the letter we sent out, but it kind of is the model we're working with, and the learning sessions, or the IHI model. Lynn, feel free to chime in if I say something wrong. With each learning session, we had an action period. We did hospital collaborative work, and then we had different presenters and training, Dr. Boutwell, and we had Dr. Weiss with the health literacy, and then we celebrated and presented posters in September. So we're going to be doing this again, and Lynn's going to talk a little more about this for this next year. Here's pictures. I thought it'd be fun to share a few pictures I had. So at our annual conference, so during the year of working on the collaborative, each team produced and developed a poster. Everyone was kind of in a different place, and some people got through to different parts, but everyone really collected the data and looked at the readmissions and did a poster. And so we have the Providence team, we have Manilic and Bartlett. So I thought those would be fun to kind of show. And this was like a highlight of our annual conference to showcase these folks and all their work. So one of the things we really looked at was what were the lessons learned from this year? You know, there was a lot of challenges with COVID and meeting in person and just all kinds of things. Staff, you know, staff was so limited, and we had, you know, so much turnover, but everyone really kept with it. We were really excited to see out of 10 hospitals, 9 really completed it. So that was great. But one thing was everyone thought, we met with hospitals and said, okay, what can we improve? What should we do? What did you think about the project? We had a meeting, everyone kind of gave us their ideas. And one thing that came kind of out was that it was a little too short. We want to keep working on readmissions. And that was why we're like, okay, even though it's not part of the Flex QI like requirement for this year, we wanted to continue and do this another year. And one of the things was that came out a lot was on health equity and social drivers of health and limitations to getting that data. So that was another reason why we wanted to continue this for the next year. Some of the benefits we really felt was working together, getting to know each other, working collaboratively, and really looking at our readmissions, and had a lot of successes there with some of the facilities that hadn't really been able to look at that and collecting all that data. So that was really, there was a lot of great benefits and we really enjoyed it. We're looking forward to the next year. And this was kind of the poster we had to create for the Flex and for HRSA. And so it has a lot on here, and I know you probably can't see it very well, it's small, but we will put this in our website. We have a website we'll be giving you later that has all of the posters, including this poster, so you can kind of look at it a little more if you didn't get to see it. And one thing that was really exciting that Telegen really decided to submit some posters of work, because we're in the Telegen HQuick, and they submitted a few different ones, and we're the only ones that got accepted. So we're going to be in the gallery walk. This poster, they kind of redesigned it a little bit. You can see it looks a little different. And Lynn's going to put that link in there. It's a free conference, the CMS conference. I think it's in May. Is it May, Lynn? And or is it April? Maybe it's April. I don't know.
Just putting in the link.
Okay, great. Anyway, there might be a time where when during the gallery walk where people can come in, and it's all virtual. People can ask questions about the project. So that was exciting. And one of the things I mentioned this on one of the really things that came out of it, that was the fun part that came, I mean, fun that we got to design and work with artists and work with Recover Alaska, because after looking at all the diagnosis codes for all the readmissions, we saw that alcohol-related diagnoses were the prominent reason for readmission at all the rural and cause. And alcohol and mental health equated to almost 50% of the readmissions. And so we kind of worked with Recover Alaska to put together a toolkit focused on alcohol education for everyone, not just people that might already have an alcohol problem, but really to try and bring it to reduce the stigma and just bring it to everyone to help with readmissions. And 4 of the facilities that were part of it, the only one not continuing is ANMC, but 4 of them have agreed, and I've sent them a box of materials with stickers. We got 4 different slogans to kind of fit so that people can pick which sticker they might want, and then it has a QR code and they can link to a website to learn more. But forget me not, remember more, don't get sideways, don't get slost, and fly sober. So that was kind of a fun thing that came out of this readmission collaborative. Okay, and actually we're all kind of taking turns. You don't have to listen to me too much. So Kate's gonna take over from here.
Yeah, so this is just a quick overview of the collaborative for this current year, and then Lynn's going to go into a little bit more detail about some of the specifics. But basically, as Debbie said, last year was really successful. There was a lot of progress made, but people wanted to continue to work on this issue. And we wanted to try to bring health equity into it. So the three overarching goals for the year, increasing the collection and use of this real data, increase cultural competency training, and then increase diversity at the leadership and governance levels. And so the idea with this is that when we look now at readmissions data, hopefully we'll be able to learn more about the people who are experiencing readmissions at higher rates. Are there certain social determinants of health that are causing them to come back? And are there some targeted interventions that we can do to really understand more about what's going on? And this is going to be through hospital meetings. So we're having our first one today in March, and then there'll be another one in May and June. And then we'll have learning sessions in April, May, and September. And we're really lucky and excited that Dr. Anthony Eiton, who is pictured there, is going to be joining us for the learning sessions. He's a really engaging, amazing speaker and a health equity expert. So that'll be really cool. And then why health equity? So we know looking at health equity is important. Obviously, it's the right thing to do. But health equity and social drivers of health play a major role in readmissions and health outcomes generally. So it's really important. But also, if you guys have probably noticed, health equity is coming, whether we're ready or not. So it's one of the main pillars of CMS's new strategic plan. For Joint Commission accredited hospitals, there are going to be 6 new elements of performance that you'll have to meet focused on health disparities. The CMS IQR reporting program has 3 new measures focusing on health equity. And then if you guys joined us for the review of the MBQIP proposed measures, those also mirror the 3 new CMS measures. So these are things that we're going to have to start reporting on one way or another. So we thought we might as well get ready.
Thanks, Kate. So I'm going to talk a little bit about the methods and framework that we're going to be following again for this 2023, and you'll see this is familiar from 2022. We're following the IHI collaborative model for learning and action. So we have learning sessions. We have 3 of those, and each of those learning sessions is going to be led by Dr. Anthony Eiton to really look at health equity and ask some of those hard questions like, what is the hospital's role in health equity and improving the general health of the overall community? Some of the questions are difficult, but they're worth thinking about as we look at how we design and focus our interventions with our patients in our facilities, whether it be hospital or long-term care. So we're again having the learning session, and then in between those learning sessions, the hospital sessions for us to come together, talk about some of the resources that are being provided in our framework, talk about what we've learned over the past month or 2 in the work that we've done individually and then collectively. And I think there's so much power in hospitals coming together. And if you can take the best of what everybody's working on, how can we potentially have an impact? Our last session in 2022 really has that focus on alcohol use and standardizing that conversation and destigmatizing conversation around use of alcohol for all patients within hospitals. That's piloting right now. And then who knows what will come out from our collective work together around health equity. Are there commonalities between our communities? Is that something that we can move together and move on with potential legislative action or collectively with all of our facilities to help make an impact and a positive impact for our communities? So go ahead and move to the next one. So you'll often hear me talk about the 4 disciplines of execution. And this is one book that I highly recommend to every leader and every manager that's working on any kind of performance improvement project within facilities. And it also pins and under kind of scores the work that we do on these projects of creating a cadence of accountability. And so that IHI framework does that as well between our learning sessions and coming together. It's that cadence of coming together that creates that focus on this wildly important goal, because one of the distractions is the whirlwind, which is everything else, right? We've all got huge agendas of multiple things going on our calendars. But the only way that we're actually really going to be able to make improvement and focused intervention work have an impact for our patients is if we actually focus on it and spend that time together to actually make and strive towards achieving our objectives. So that's one book that I highly recommend. If you haven't read it, download it, read it. It's quick to read and it provides some great resources and information along the way. We'll go to our next slide. So the 4 disciplines talk about our focus on the wildly important, acting on lead measures. So in a driver diagram, those would be those that have an impact on what our goal is going to be, creating compelling scoreboards. So making this activity and this work visible within your facility, showing that readmissions is a large focus for your facility, that this is a priority focus and that you're working together internally and externally with other hospital partners across the state to have an impact on reducing readmissions for patients across the state of Alaska. And then also creating that cadence of accountability that I talked about. Not only do we have that with our IHA framework, but then also internally with your teams, a consistent time of meeting and map that out as you look at how you're going to work together as a team through this next year. Next steps. So as Debbie mentioned, we're going to be using the Aspire Reducing Admission to Whole Person Transition and Care. And I think we'll be uploading the link to that. We're going to also be uploading the invitation or sending out the invitation letter again with some updated resources on it. And the links will be in that letter as well. But from the work that we did last year, that this framework continues to this year, that one of the most important foundational pieces of our work together is analysis, and to help drive the reduction, analyzing your data, surveying your patients, and then creating that portfolio of strategies that using this information to drive your interventions, that your interventions are based upon the data. So it's data-driven interventions that can really then have that impact. Okay, next slide. One of the first homework assignments between now and our next meeting is going to be updating Tool 1 with real data striation. So we added a few more components to Tool 1, which is also in the first tool in the Aspire framework. For those of you that participated last year, you all completed Tool 1. So it's just updating it for 2022 annual data. So it's going to be kind of nice because you'll have a comparison then, because you did 2021 and now you'll be able to do 2022, look at some comparison. But in 2022, there's some additional levels to the data, including not only race and age, but we also included the ethnicity and language components that'll feed into your graph dashboards in that tool. So Debbie uploaded that tool for you to download and share with your team and start that process of looking at your 2022 data for readmissions. So that'll be one of the first things to do. The other thing we wanted to let you know about is in the initial invitation letter, we sent out a bunch of links regarding the toolkit we were planning on using, which was the AHA, American Hospital Association toolkit. But and drilling into it just to find specific elements that we thought would be helpful. But since then, we've been participating in the HSAG. It's a quality improvement network like our HQuick. And they have developed actually a really excellent health equity series. And they're little quickeners, they're 15 minutes with some great discussion, but they lead really well into the work that we're doing. And they also work really well, they integrate well within the IHI framework, and also creating that cadence of accountability. So one of the other takeaways will be we're providing the links to this Health Equity Quick-in-Our series, and that also will be a piece of the work that your teams do between now and our April meeting. But there's 13 sessions. And then there's also a number of other resources they have that we'll be updating into our initial invitation letter. And we're going to be sending that out probably by tomorrow again, with some additional resources for you and your teams to look at. But the beauty of these is they're quick. They're really reflective of adult learning. So short snippets of pieces of information that you can take away and then utilize with the work that you're doing. So we're moving away from the AHA toolkit, which was really huge and quite cumbersome and kind of overwhelming, to what we thought was a better streamlined focus on health equity with a series of information that can be super helpful and engaging for your teams along the way.
I was wondering, has anyone watched them? Because we did put them in our QI news, and I was curious if anyone's seen any of them. No.
I have, Debbie. Can you hear me?
Yeah.
Yeah, this is Deb Couch. Yeah, I
Oh
started
yeah.
watching.
What did you?
Yeah,
What did you think?
I started watching right away. I recommend them for everyone. If you guys have a chance to watch them, they're amazing. They're really my go-to now. I think we're only up to number. I think we're only up to number 5 now. But the HSAG is doing a fantastic job. So yeah, highly recommend it.
The first. That's great to hear. The first 5 are recordings, and the first one is actually 40 minutes. Like I was surprised to hear that. And then the 4th one is 15. So they're all variable. They're mostly under 30. They're
Lindley chatted in, she agrees as well. So that's awesome. Because as we started watching this series as well, Debbie and I looked at each other and said, we like this a lot better than that cumbersome toolkit. So we really thought this was a better approach. So that's cool. You guys are already in there and familiar with it. And then these are the tools that we'll be using through this next year with our collaborative.
Great. And that's great that Michaela and Lindley from Valdez joined. So glad to have you on there, and glad you could join. Okay.
And then the other resource that's going to be available again this year is an online collaborative website, and you'll have a password to sign into it. And we're in the process of updating all of the links, especially since we shifted to a whole new toolkit. So we want to make sure that those are all updated and in line and in place before we send out a refresher to you of where that website is and the password. It's an opportunity to have a variety of resources in one place, all of the tools and resources that we're using, and then also recommending to teams as you work on your performance improvement projects. There's additional tools in there with PDSA worksheets, A3s, fishbone analysis tools, their 30, 60, 90-day goal sheets, and priority mapping resources. So if you're planning a meeting with your team and you want to grab a resource to look at a root cause analysis or something like that, there's some tools available to you on that website as you work through your interventions with your team.
And this picture, some of them might not have been there, but this was Dr. Botwell presenting a breakout session on readmissions there in September. So, oh, do you want to introduce what we're doing now, Erin?
Yeah, sure.
Okay.
Yeah, so during our first kind of meeting today, we're going to go through all 4.
Oh, Erin.
Oh, sorry. I accidentally hit the mute button. We're actually going to be going through kind of just like a brief overview of the 4 videos. The first kind of 4 that are actually live, a part of the HSAG series. So I'm going to be going through video 1, health equity, hospitals, and CMS reporting. So just like a quick overview and just some of the highlights and takeaways. And then a part of the homework, like Lynn kind of noted, we're going to ask you guys to go through and actually watch the first 4 videos. Or I think I'll have to go back to the next steps, but it could be the first 5 videos before our next meeting.
Yeah. 4.
So the first four. Great,
Mhm.
thanks. So video one really goes into some introductions on disparities, health equity, social determinants, and how this aligns with upcoming CMS measures. So there's many reasons to focus on health equity. Like for one, it's the right thing to do, right? But we also know that disparities have an impact on increasing readmission rates, non-compliance rates, emergency department utilization, and increase in chronic conditions. And one of the things that resonated with me with some of the commonalities and topics that we've been discussing or hearing about over the past year, and some things that I heard or that we'll all hear in video one, was if you were in attendance during the September AHA conference with, and you were able to listen to Dr. Eiton, he talked about specifically how one zip code is tied to one's life expectancy. And they also touch on this here. And I think we're lucky enough to have him again to be one of the speakers and kind of helping us during that learning session in April 17th. So don't forget to get signed up for that. It was obviously really memorable. And that was like the first thing that kind of popped into my mind when it came up in this presentation. So also with health equity, it's like looking at those social determinants, which are drivers that we all know. And one of the things that they talked about that was another takeaway that I think was interesting to note, an article from the National Academy of Medicine, and they have the link in the video. They noted that you can do everything right, you can deliver perfect health care, but 80 to 90% of your patient outcomes are dependent on their social determinants of health. That's why this is such a huge factor to focus on and why it's so important to address social determinants of health with your patients and in your community. So I think that's, I mean, we all know that, you know, they're not in our facilities, you know, for most of their life. They're out there living out there in the world. So looking at those social determinants of health to make that big impact on their outcome is important. And I also appreciated they touched on kind of like rural populations and how, you know, in critical access hospital areas and rural areas, they may not have a ton of diversity, but that doesn't mean that there's still not a lot of disparities that we can identify in our communities related to social determinants of health. So for example, food insecurity, housing, transportation, and they kind of really honed in on the message of, you know, the hospital focusing on what are the needs of the community and looking at how we address social determinants of health at the community level. So really getting outside of our four walls and kind of looking at what's out there and available. They also kind of touched on hospitals in many scenarios are like the hub of the community. And they really talked about that on the aspect of during COVID, like, you know, the hospitals were really kind of like that main source of information, the main support system. So I think your communities really look to you all, and I've been to quite a few of them, and I do agree with that absolutely wholeheartedly. So I think this is a great project that we're looking at, and this video is really just an introduction of kind of health equity and kind of social determinants of health. The other half of this presentation of the first video was talking about the alignment with the CMS measures. So they're upcoming CMS measures and prospective MBQIP measures. So again, not solidified, but we had a meeting maybe last month talking about the proposed MBQIP measures, and these are them. So the ones related specifically to social determinants of health and health equity. So the first one is the commitment to health equity, and they kind of briefly high level go over it. They talk about the 5 domains. So domain 1, the equity is the strategic priority. Domain 2, data collection. Domain 3, data analysis. Domain 4, quality improvement. And domain 5, leadership engagement. And that's going to be an annual reporting measure starting in 2024. So next year would be the first year that you can start reporting on that. So then the other measure, which is kind of broken out into 2 parts, That's the screening for social drivers of health. So that's food insecurity, housing, transportation, utilities, interpersonal safety. And this measure is really looking at how many people were screened for social drivers of health. And the second part of that is who was screened positive for that rate of social drivers of health. So how many positives were related to each one. So how many were food insecurity, how many were housing, how many were transportation. And they kind of noted in the quickener that this one might take a little bit longer for hospitals to kind of like get set up, get training, get data collection going. So this one is actually not going to be reported or required reporting until 2025. And this one will also be an annual reporting. And they said that they do have resources and tools available to kind of take a look at all of these upcoming measures. And I think the main key takeaway was just the time is now. There is no better time to start looking at these things than now, and looking at social drivers of health and getting these things set up and getting your teams put together before it's required to be reported.
Hey, before we go on to the next slide, Debbie, I know we talked about doing a poll and then we scratched it this morning, but if you could put into your chat, how many, can you go back to the last slide for a sec?
Yeah.
So if we look at screening for social drivers, D codes in hospital systems through coding are utilized to do that. So I'm wondering if you could just put into chat your hospital, and if you currently have a program in place or planning a structural measure in place, I guess, or structure in place to obtain Z codes systematically within your facility. So it would just be a yes or no. Majority of folks, or majority of hospitals I'm aware of don't have a structured process in place. But if you do have a structured process in place, I'd love to hear that from you in chat. So if each facility could just put in your hospital and yes or no, that would be awesome.
Yeah, and I think most have with their name, they have their facility. So great. Thanks, right. Jeanette. Yeah, if you guys put that in, that'd be great. Okay.
Thank you.
Okay, so video number 2 is all about engaging leadership and health equity. We know that things aren't going to, these initiatives aren't going to be successful if we don't have leadership buy-in. So it's all about how do we engage leadership in health equity efforts. Like we've all said before, it's the right thing to do for patients, but there's also an important business case to be made. There's a lot of money to be saved in addressing some of these disparities. Like Aaron said, 95% of healthcare expenses are medical, but only 10 to 20% of outcomes are actually related to the medical care provided in the hospital. So even if you do everything right, if you send someone home to an unsafe living environment, they're going to be back. And it touched a lot on the idea of non-compliance in patients, and that we call patients non-compliant, but really it might be that they're just not able to comply, due to the conditions in which they're living. So that was really important. They also talked about dual eligible individuals. So those individuals who are eligible for Medicare as well as Medicaid experience preventable readmissions at an 18% higher rate. And that's because those are the populations that you see really struggle with some of these social determinants of health. And then, of course, like we said before, quality reporting programs are moving towards reporting on equity measures. And so soon some of these things are going to be required.
Great, thanks, Kate.
So the third video also then moves into health equity as a strategic priority. And each of these videos kind of build on each other and also provide you with some really good resources to put together a value proposition for your leadership. If there's team members that you want to be on the team or that you think would benefit to be part of the team to improve your efforts, you can utilize some of the resources and tools from these videos to help develop that portfolio or proposition for leadership to help if there's some struggles around, staff time or other types of resources that you might want to purchase or work on. It can provide you with some great information to guide you with that information that you want to provide in that message. And also, you'll see that these videos also align really well with the Aspire framework, not only having that data-driven piece in Tool 1, but then also looking at your intervention priorities in assessing your environment, and then also interviewing your patients so that you can understand what those social drivers are that are resulting in readmissions. And one of the stories that really struck with me that Dr. Boutwell shared last year was a patient that was frequently being readmitted, and she had COPD, but one thing they found out as they interviewed her one-on-one was that she was going home to sleep on her children's couch, and they were providing her with coupons to a fast food restaurant, which was her favorite place to go, which was super high in sodium, and then also exacerbating her medical conditions and resulting in her readmissions. So had they not done that interview with that patient to discover what actually was going on so they could provide some family-based education and intervention, that patient would have just continued to come back and health also continued to deteriorate. So having those tools that in the Aspire framework and following those along with these health equity videos also then helps address looking at those social determinants of health. So one thing that was pointed out in this particular video is that your community health needs assessment, which all of our facilities do, is not and does not address health equity. It really talks about your community needs, but it doesn't address where those specific issues, if they were intervened on, might be able to benefit the health of particular individuals or populations within your community. So addressing disparity needs to be a key initiative for facilities that are receiving Medicare and Medicaid funding. And as we've heard over multiple times already this afternoon, about it being the right thing to do and just focusing on the health of our communities.
Great, thanks, Lynn. And the last video I'm just gonna briefly go through is the one on real data. And the first bullet is just the definition of what real data is. And the key, they kind of said the gold standard is self-reporting, but it can't always happen in terms of that. So sometimes it depends on the patient population and the facility, but if they can self-report what their demographic information, that is really key. And the next thing is that the kind of point they made is that it should really align, the data elements really need to align with not just the Office of Management and Budget's definition, but the local community, and that often community organizations can really help with looking and defining what those data elements should be that you want to have that they can self-report on. They went into that those that are helping collect that information, though, should really be trained in the best practices, because it can be difficult and how to really learn how to collect that information when you're working with a patient. And then the last two bullets really, they just really talked about these two things are very essential for quality improvement, and to have reliable data, and to look and make sure and do validation of that data by observing the interactions with the patients and the staff that's collecting it, and that to make, and we just talked about who's doing it. It looked like most of Z codes aren't collected in part of the medical records, and just that this really supports quality once those Z codes are part of the medical record and their real data. And then the key takeaway was really, to me, was just once you get all this and you have the real data, then you can really stratify and look for the priority populations that you want to work on with readmissions. So I wanted, does anyone have any questions on those videos or anything? So we just kind of did an overview, and we did put the link in there for you to register for those, but you can watch those recordings. And then I just want to move on to the April 17th. We've talked about this a little bit. Please register. We would love it if you can attend. Dr. Eiten's going to be there, and we can, most hospitals, we were just supporting maybe one quality person, because we also are supporting a long-term care committee member and a CNO committee, but we can try help support 2 from your facility. And if you have needs for more, let us know, depending on, you know, how much funding and how many people ask for travel support, we might even be able to do more. So we just would love it if you can attend that meeting. And there's a link there for travel authorization too, that I think she put in. So that's how you can complete that to get your travel reimbursed after the trip. Does anyone have any questions on the April 17th event? Oh, one other thing, the session that Dr. Eiten is doing from 10 to 11, we are going to hopefully stream that just for the folks in this collaborative. We don't want to make it, you know, so that way if you can't be there, and I know like Bartlett, you have a big team interested. So if we can do that, and then we can also record it. And actually that's kind of more important, like record it, then people can watch it when they can. So we're hoping to record that. I guess we could always record it another way if that didn't work, but I think we should be able to record that on Zoom, that 1 hour, the 10 to 11. And then Erin's gonna wrap us up, and then we'll have a few minutes for questions.
Yes, so thank you, Debbie. Yeah, so again, just echoing, making sure you get registered for that April 17th event and complete your travel authorization, like Debbie just noted. Dr. Eiten, like I said previously, he was a phenomenal speaker at the September event that AHA hosted. So I think his session will be phenomenal. It will be the rest of the day. Also, so next steps for this group is to download the Aspire Tool 1. Was it put in the chat today?
Yeah, it was put in the
Okay.
chat, and once we
And
get
it's
that,
on that
yeah.
Flex website. Yep.
Once we'll send you all by the end of the week. We'll update that website.
Yep. And then just make sure you get registered for those Quick&R series. They started in January. The first 5 recordings are available. They do the actual recording, and you can also download just the slides too. So we're asking before the April 17th meeting with your team if you can complete the webinars 1 through 4. It sounds like some of you may have already watched them, but if you could at least get those webinars done before the 17th meeting, that'd be great. Also, hospital teams, make sure you have those formed by the April 17th meeting as well. And I think we're going to be scheduling our next May hospital meeting, May 9th at 3 p.m. And Debbie will get those invites sent out soon.
Does May 9th, is there anyone that just is a really bad day? Because we're flexible that week, you know, or email me or put in the chat if that's a really bad day or time. We want every team to be able to at least, you know, send a few people. So yeah, let me know if that doesn't work for you. I probably won't send that out for a few days for May 9th. So send me a message if your team can't make that. And
yeah, and thanks everyone for coming today, and we look forward to seeing you all on the 17th.
Well, that's also, yeah. And before you, take off, does anyone have any questions? Oh, yeah, I will, yeah, we'll have all the links from today. I can put that in the email tomorrow. We're going to update the letter by tomorrow, and we'll send the letter with all the links from today. And then all of that will be on the website. All the links from today, everything will be on that website too. But yeah, we'll try and send that out tomorrow with the links. Does anyone have any questions? Anyone comments, thoughts? Does this seem doable to everyone for the year? And
Hey, Debbie.
yeah.
Hey, this is Deb Couch. Hey, just wanted to tell the group too, back to the Health Services Advisory Group Quickeners. It's an excellent place for questions. I've just gone every other week and just gone in with my questions that I have about the social determinants of health, like reporting data that we're going to have to start inputting every year and just the other pieces of it. And I have just brought all my questions and they are really, really great to answer. Even though it's a 30-minute webinar, you just pop your questions into the chat and they just address them. They've sent links. I would just highly recommend it to everyone. Working on it.
They answer the questions during the webinar, or you mean
yes,
they email you?
Yes. No, they address it live, like, so boom, they're answered. So anything I've had, I have just taken it to that webinar and just popped it. I don't think I had any questions the last one, but all of the other sessions I had questions, just popped them in there. So it's a really great kind of forum to ask questions where you can get like a live response. So
yeah. Oh, nice. That's nice. Yeah, you can't see who else is on. So, but I might have seen them answering one of those questions then. I don't know. I think those are in the recordings too. They answer them.
Yeah, they are.
Yeah, I think so. Yep. Yeah.
Okay, well, we're a few minutes early. So if you have a 3 o'clock, you can take a little break and get some more coffee or water.
And if anything comes up, feel free just to shoot us an email.
Yeah. And if you add anyone to your team or anything like that, let me know and I'll make sure they get invited to everything that's coming forward. I have who you put on your MOA when you submitted that, but if you add anyone, please send me their email and I'll add them. And anyone from your team is welcome to join at any part of this process this year. So
thanks, everybody.
Yeah, thanks, everyone. We'll see you later.
Thanks, guys.
Great to see you.
Good afternoon.